Thank you so much for the opportunity, and I see this is quite an audience, so it's really a privilege to be able to speak to you today. I must say I thought it a little bit ironic, the definition of an intensivist, how we do, evidence-based medicine, and our skills generally are quite good to get us through. And if anything, this pandemic has felt like we didn't have that evidence, especially in the beginning. It's been really an interesting journey. We arm ourselves usually with skill and knowledge, and both of those were really only being developed during the pandemic. So today I'd like to share with you from there's some science, but there's also a little bit of the art of medicine involved, and some of my experiences. And really what I'd love to hear is from the community, what your concerns are, what your queries are. So I'm just going to share my screen quickly. Let's quickly go there. All right, so I hope you guys can see my slides.
Yes, we can see it. Thank you.
Perfect. Great. So this is basically what my world has been for the last 18 months. So what you guys are looking at is the Professor Anton Stoltz COVID-19, what we thought was going to be our only ward, but turned out to be just the ICU. So before I say anything about COVID or infectious diseases, of course, the great pioneer of our COVID response was Professor Anton Stoltz, who was my dear colleague and friend, and who left us way too soon. But we started this ward together last year in March. We started a process of intensive training. We realized from our colleagues overseas that we were in for one heck of a ride. I must say at that stage thought it was going to be a 3-month ride, not a 2-year ride so far. And we used what was previously the TB ward at Tshwane District Hospital and got that ready to manage the anticipated patients with COVID-19. And so over the last 18 months, many hours of my day and some of my nights have gone into this particular unit where we treat our patients at Steve Biko Academic Hospital. What we've done is we've split the two. Tshwane District is our sister hospital, and we've made Tshwane our COVID hospital and Steve Biko our so-called clean hospital, and we've just provided specialist services on both sides. So these are just a few more pictures, just giving you a little bit of insight. So at Steve Biko, when you arrive as a patient and you have respiratory symptoms or you potentially have COVID, these are the much discussed in the media as well, tents on the left-hand side, where we have patients while we wait for their COVID results. We've had to do things a little bit differently. In the middle, you can see my colleague who's in PPE, and all that our patients can see is our eyes. And so we tend to write our names and what we are. It must be very intimidating for patients just to have this sea of masks coming at them. And then, of course, COVID has taken its toll. So, on the right-hand side, that's one of our ICU sisters, Sister Lushka, coming off a 12-hour shift in the ICU. And you can see it is quite grueling in PPE. So just a little bit of background. Right now, we're more than 18 months into the pandemic, and we don't have a definitive cure. We have certain things that we know work. We know that early steroids work. We know that tocilizumab at the right time works to decrease mortality, but we do not have a cure for COVID-19. And if you look at the years of literature in infectious diseases, really our best chance is prevention. And that horrible cliche that prevention is better than cure certainly comes to play with COVID-19. So what I've got here is just a graph of the reported measles cases in the United States, because we're quick to forget that this isn't the first pandemic, that this certainly isn't the first vaccine. And I was interested in my reading also to find that many of the vaccines were developed quite quickly. I think they were just less played off in the media. So as you can see, the reported cases of measles, when you had the inactivated vaccine, and then when we got the live vaccine, and eventually when we got to what we use today is this MMR. And this is really standard of care today. And today, kids aren't really dying of measles like they used to, and adults. And if we think about the morbidity, the mortality, and the collateral damage of COVID-19, really it has been massive, and it's something that we have to get on top of. So what's the big deal? Well, this was the 3 waves that we've had in Gauteng. And we've just come off the black wave. You can see our 3rd wave, which has now officially been declared over. But this has been a grueling and very, very long wave for us. We didn't have enough beds, we didn't have enough ventilators, we didn't have what we needed to deal with the kind of numbers that we were seeing. And I'm not just speaking about states. If you look in private, many plans had to be made, makeshift ICUs, makeshift wards, tents erected in some of the hospitals as well, just to deal with the numbers. And what we thought was going to be the original winter wave, the blue wave, got followed by a summer wave, and now followed by a massive 3rd wave. And the life lost in that time, I think we become a little immune to statistics that are just spewed at us every day. Oh, another 250 dead, whatever. But for us, those statistics have faces and names, and some of them are patients who looked us in the eye and asked us, please, you've got to get me through this. So certainly this is quite a big deal. So I'm not sure how everybody's medical knowledge is. It's really easy to know a lot about COVID. There's a lot of good information out there. There's, of course, also some misinformation. But just as if we look at how the vaccines work, then there's a better understanding of some of the myths. So really, if you look at COVID-19, the key elements that we're looking at is, of course, the RNA and N protein, and then the spike protein, which are the 2 proteins that really we can target when we're looking at the vaccination process. The 2 major vaccines that we have in South Africa at the moment is, of course, the mRNA or Pfizer vaccine, and then we have the J&J. Those are our 2 main ones at the moment, and more will follow. But just to give you a broad overview of how the mRNA works. So first of all, I think it's important to know it's mRNA, not DNA. Many people are very concerned about DNA and DNA changing. So really what it does is this messenger RNA is the blueprint, if you wish, for a single protein on the virus, which is called the spike protein, which if you look here, you can actually see over there. So it contains the recipe, if you wish, for your cells to make that spike protein. And when your immune system recognizes that spike protein, it immediately mounts an immune response. It sees it as foreign. And it's that immune response that we then rely on should you be exposed to the actual SARS-CoV-2 to then create an early immune response and get on top of your infection earlier than if you were just experiencing the infection for the first time. Then, of course, we've got the vector vaccine. This is in the case of AstraZeneca and, of course, J&J, where you use a virus with the genetic material, again, from the spike protein. This is important because I've had numerous people come to me who've tested after vaccination for antibodies. And what they don't realize is many of the labs test for the N antibodies, which are actually what you get with the full infection. What the vaccines gives you is S antibodies. And many people have come to me and said, but my vaccine didn't work, I don't have any antibodies. So again, just remember it's the spike protein that we have these antibodies to. And again, similar, we basically then prompt an immune response by priming our immune systems to that. And I know many of you know a lot about vaccines and immunology, so I'm not going to bore you too much with the details, but then of course there's also the protein subunit vaccines. And at the end of the day, it's all about recognizing a part of the virus and then mounting an immune response. So a few of the myths that I've commonly come across and that patients really are concerned about is, first of all, the idea that it's a live virus. Now, we know that it's not a live virus vaccine, so you cannot get COVID-19 from the vaccine. It can feel like you get COVID-19 for a day or two because you get typical symptoms sometimes. You can get fever, you can get severe body aches, headaches. In fact, especially if you've had COVID before, or very often with your second mRNA vaccine, those are the kind of symptoms you get, and it's a good sign. It means your immune system is actually reacting, but it is not a live virus. Of course, if you had COVID underlying and you didn't know it, you can still get the infection, but it won't be the vaccine that actually gave you the infection. The other myth that is really punted in social media is the idea of altering of DNA, interfering with fetal DNA, pregnancy, causing infertility. because of a recognition of foreign proteins. These are really not substantiated in any significant way. Many people have also brought forward a safety concern, saying, has this been adequately tested? What about the time period? And I think what we need to understand is, unlike some of the diseases which we face in sub-Saharan Africa, which are very local diseases, they're very developing world diseases. And so the vaccine processes sometimes they have been a lot slower. This is a disease that has shaken the entire planet and many economies. And really, I don't think we've ever seen the kind of collaboration between researchers and the pooling of scientific resources like we have now. And it's also important to remember that our scientists are quite bright. Our virologists have been expecting for some time. They've been waiting for a virus to test the platform on. It's not like the mRNA technology is completely new. The technology was there. They were just waiting for the anticipated pandemic. I don't think any of us thought it would be corona, which is usually associated with common cold, though. The idea of not having proper time for testing, again, our numbers are global. So the FDA, even SAPRA, those, as many of you know who've been involved in trials, those are really tough regulating bodies. And I don't think their standards have been compromised in any way. And the safety data is there. There's been transparency with side effects, which have very often been grossly misconstrued in the literature and in the media, and sensationalized. But if you put them in context, I think there has been transparency. And I really do think that the kind of numbers we have reached in terms of vaccination globally can give us security and the safety signal. A very common misconception is that the COVID vaccines will prevent infection. That is not the point of vaccination. The idea of getting your vaccination is that you don't get severe disease and that you don't end up in the intensive care unit and you don't end up dying from COVID-19. There's not a 100% guarantee, of course, but I'll show you some literature just now, which certainly shows that in terms of severe disease and mortality, these vaccines are highly effective. It's important, even if a subset of our population still require ICU, to understand that the burden of the waves on intensive care greatly outweighs our resources. So there's hardly a physician or an ICU specialist in South Africa which has not been faced with some really tough triage decisions. Who gets the ventilator? How far are we going to push somebody before we have the ventilator available? Futility of care, all of these issues which we deal with on a much smaller scale on a day-to-day basis explode during the peaks. And really that's why it's so important to prevent severe disease. So safety, we've got good phase 3 clinical trial data. We've got the regulatory boards on board. The only real contraindications is if you've had severe anaphylactic reaction in the past, and then again, discuss that with your physician, because what one person sees as an allergic reaction is not necessarily anaphylaxis. And then the data in children under 12 was pending, but certainly it's coming through now, and safety signals. That data has just been submitted for Pfizer for children between 5 and 12 as well. So hopefully we can see that pretty soon. And in fact, my son said to me the other day, he's a 9-year-old. If he stands really tall on his tippy toes, he's sure he can pass as an 18-year-old. So you can see that the vaccinations are quite a theme in my household. Contraindications, previous COVID-19 infection is actually not a contraindication. It's also not a guarantee that you have immunity. So some of the work that we've been doing is looking at immunity over time from natural infections as well as from vaccinations. And some of that work is in publication. But we know that a second challenge after natural infection is really beneficial in terms of the immune response. If you've had severe COVID-19, of course, you're not going to go for your jab as soon as you're discharged. So depending on the severity, at least 30 days after recovery. If you were in ICU, you probably want to give a longer period of time. And the data is out there for anything between 2 and 3 months, depending on the severity of your illness. Immunosuppressive medication is not a contraindication either. You should know that your effect of the vaccine will probably not be as robust as in people who are not using immunosuppressive medications, but certainly some protection is better than nothing. And if you've had previous, people say to me, the flu vaccine makes me so sick. And I always say to them, great, it means it works. So if you've had just flu-like symptoms before, that's not a contraindication to vaccination, because there is a lot of fear around the symptoms of vaccination. All right, so this is a terrible photo, but I share it because I remember that day. Throughout the first and the second wave, throughout the first wave, we were all just hoping for a vaccine to be developed. And this photo was actually taken by one of the members of the media, and it was the first day the vaccination program released here at Steve Biko, and I got my vaccine. And I remember that moment. I really felt like this was the first moment where there was a glimmer of hope for us. And in the second wave, I was one of the big proponents saying we're not doing enough to secure vaccines. We're not doing enough to get vaccines into the country. We need to partner, government, private, everybody, just get the vaccines in so that we can start vaccinating. And the one thing that on that day I did not expect is the kind of vaccine hesitancy that we are seeing. I suppose my perspective is severely biased by the environment where I work. I work in ICU, and by the time you meet me as your doctor, you are severely ill. And the majority of people there completely lose any vaccine hesitancy. So to see that to date, we are really far behind where we thought we would be has been a little bit surprising, but it's also been really demotivating for the colleagues. I'm seeing a lot of negativity among doctors and nurses on the front line who are starting to feel the brunt of the last 18 months. I mean, the majority of us have worked 2-3 times the kind of hours that we would usually be expected to work, and done calls. And I think what people don't realize is the normal stuff still happens, right? Asthma, COPD, HIV, all of those things haven't gone away. COVID was on top of it. So the initial extreme, I suppose, overly optimistic hope that we had in the vaccines has been shaken a little bit because of the uptake. So why is, what's the issue? So, I mean, we know we were slow to procure, and maybe that was part of what created some uncertainty. There's definitely been a plateau in uptake. And what I suppose happened is all those who really wanted the vaccine were the first to go and get it. We really are still far from the target that we need if we're going to get any sense of normality back. And I've spoken to my colleagues in the UK, and where they are still seeing numbers. They are still seeing patients with COVID, but their ICUs are not overly full. And certainly they are returning to a version of normality that's a lot closer than what we've been for the last 18 months. So what are the reasons for vaccine hesitancy? And I suppose really what we need to do is get down to the various levels at which this occurs. I think misinformation, I'm just thinking, if I am faced with a decision out of my field and I go and do research and I have Google available, if there is this insanely contradictory amount of information, because on the one hand, you've got people saying that, this is going to be effective, we're going to prevent severe disease. And on the other hand, you have got these pictures of people who are clotting to death and people who are punting side effects. And of course, people who feel that there is a conspiracy theory behind this, that we'll see how you do in 2 years' time and we're going to turn into zombies. I mean, the kind of deluge of information that is available on the internet makes it very difficult for people to really decide. And there is, of course, there's a lot of mistrust in governments. In institutions, we've been let down many times by those who are supposed to protect us, those who are supposed to make best decisions for us. Overall, in South Africa, we have a little bit of a pessimistic outlook about whether, those in charge really are doing what they do for our good sometimes. So that could be contributing. Side effects, yes, side effects do occur. And we know that the side effects, if you compare them to, for instance, what you can get with COVID, infection, so things like an increased risk of clotting all my patients who have an inherent increased risk of clotting, we discuss this before we vaccinate. And we have a plan and we have a good follow-up to make sure that we manage that. But I think it's very interesting, and I think many people were shocked to find out that, for instance, the clotting risk, which has really been punted or really been a concern in the media, is still not as much as you get from swallowing an oral contraceptive pill, which many, many women in South Africa do every day. Other side effects such as the Guillain-Barré, a few cases that have been associated with the J&J vaccine, if you go and look at those cases, very often these people had risk factors, or if you've had neurological disease before, again, this is something you will manage with your team, with your medical team, but it doesn't necessarily mean you don't qualify for the vaccination, because again, the effects and the risks of COVID are certainly much bigger than the risk of side effects. And then there's a sense of complacency, I think. I think it's been 18 months. Many people have had mild disease. Many people say, oh, it was like influenza, I was tired for 2 days. And that is great. I'm really thankful for you and I'm really happy for you. But I think we need to be aware of the bigger picture. So I was actually looking at our clinical data for 3 waves the other day. And I was specifically looking at hypertension and dyslipidemia, high cholesterol. And I thought there was a problem with the data because there's certainly, compared to the first wave and the third wave, the comorbidities were so much less. And I see this in ICU, but I didn't realize that it was for the whole hospital. And if you go and look at the data, it's very clear that for Delta, which was our third wave, we had younger patients with fewer comorbidities. So in the first wave, we had old age and numerous comorbidities account for most of our mortalities. In this wave, this has not been the case. And the other thing is I have survival data, but I also need to look at long-term outcome data. Things like chronic COVID is becoming a real issue. We have highly functional people who, after their COVID infection, are just not functioning like they used to. They have chronic fatigue, they have pain syndromes. Myocarditis in children is coming to the fore now. So yes, you may not end in ICU, but you may actually have things like long COVID and side effects down the line. And in the third wave, what we've noticed is the length of stay has been a lot longer, and our patients were storming the so-called COVID, the cytokine storm, where they have this massive immune response that usually ends them in ICU, was more severe and lasted longer. And I think this has downstream effects because that patient blocks a bed for longer, and it becomes a huge issue in these waves where we need beds. So I think the complacency just needs to be in the context of the bigger picture. And of course, if you got mild disease, you could have given it to 3 people, 4 people before you got your mild disease, and those people may not have had mild disease. So what about my end of again, I'm very biased because I see patients in the ICU when they realize that vaccination would have probably been a really good idea, or of course, when vaccination wasn't available yet. And I thought that this was really a patient, actually, I saw him after their COVID, and we were just chatting about the process and about the process of being intubated. And he was saying to me, there's so much in the media which says that if you're in on a ventilator, that's the end. And he said to me, when you told me I was going to be ventilated, I thought, that's it. I phoned my family and I said goodbye to them. And he actually said, and I quote here, the most difficult times are the nights when you feel so alone. The nurses and doctors work tirelessly to save your life. And they're figures whom you can only make out the eyes behind the layers of protection. At the time you need your family the most, you're in danger to them. So it's you and the sound of oxygen blowing next to you and your thoughts. And I realized that, we're really busy during the waves, and we do everything we can to maintain some sort of physical contact with patients. What I'll often do is I'll go stand at the window and at least patients see my face and say, hi, this is me. I'm coming in now in full PPE. So at least you know what I look like. But what we're also seeing is we're seeing an exodus of medical staff, and we're seeing people retiring early. I've lost colleagues. I'm sure many of you know the esteemed colleagues that we have lost. And we're seeing immigrations from the medical fraternity. And of course, we are just seeing especially among our nursing staff, people who are just walking away from especially ICU. And then, basically it's because of the cycle of we get to say goodbye to a patient who we've nursed, who we've given everything to, and you have to just move on to the next one because of the burden of work. So like I said, the landscape is changing. It's changing in two directions in terms of what we're seeing with our patients, younger patients, less comorbidities, longer illness, and more severe chronic debilitation after ICU. But the landscape is also changing in terms of the healthcare workers at the front line. And where there was the sense of heroism and calling in the beginning of the pandemic, people are fatiguing, they're tired, they are burning out at an alarming rate. And I think that this will affect eventually the kind of care that we're able to give and the number of people who are available to give that care. So that would be really why, if you ask me why I'm such a proponent of vaccination, besides the science, this is what I see every day. And this is probably why this is really such a passion of mine, so important to me. Time is also not on our side. The longer we have vaccine hesitancy and procrastination, the more time we get to increase the number of Latin alphabet figures that we are going to include in our variants. And of course, we know that that has implications in terms of red listing, etc. So, will the vaccine make COVID go away? No, the idea is that it makes COVID manageable. So this is CDC data released. And I think what is really, really important to see is that, yes, people who are vaccinated still actually got COVID. But look at the hospitalizations. And if you expand this to the ICU, really most centers in the United States and in the UK are reporting in excess of 85% of the patients in their ICUs are non-vaccinated. So this is really why we are wanting to see people vaccinated. 17 times more likely to be vaccinated, to be admitted to hospital due to COVID-19 if you're not vaccinated. And the facts speak for themselves. So maybe just to tell you, if by any chance you were sort of sitting on the fence and wondering, and you are now leaning towards vaccination, we have got our UP vaccination sites. Our students are very innovative, I'm sure, in their ways that they are promoting vaccinations, everything from RAP to having the radio stations here, and a lot of fun going on. We've had a really huge amount of great feedback regarding our vaccination site, and Corin and a fantastic job. So it operates between 9 and 1 on Tuesdays, Wednesdays, and Thursdays. That excludes public holidays. It's appointment-based, so it's really quick and convenient. And if you look at the website, you'll see a lot of positive feedback. So basically, once you go up, you can either visit the portal, and then these are the steps. You can find your registration link, and I'm sure all of you know that you can find this link all over. But there's also the UP Google form to be completed. And then what is really cool is they actually contact you with a time, and their appointments are on schedule, and it's worked really well. There are numerous sites available. Of course, it's not only the site. This is just to make it easier for our UP community to be able to vaccinate. So Professor Leonie Stoltz, she's the previous head of radiology at UP and Steve Biko Academic Hospital, has actually put together this documentary. You heard in my intro, I am also associated with Zuid Afrikaans Hospital, and that's where I've had the privilege of looking after some of our UP community members as well, which really takes you into the ICU. There are real patient stories, there are interviews with actual doctors, and you'll see some real tears and some real frustration. So if you would like to see what it's like, her documentary actually features tonight at 8:30 on mNet, and that would also, if you've still got some hesitancy, it might be nice to see what other people have to say. So I'm actually going to stop speaking now, and I'd love to hear what your questions, concerns, and comments are, and hopefully we can chat around them and really understand what is happening in the community. Thanks a lot.
Yeah, some of the applause, Veronica, here in the room with me. Yeah, I must say, listening to some of what you say actually makes one quite emotional. Maybe it calls up memories of friends and family who we've lost, but also just thinking about what yourself and others are dealing with, and so many people around the country are dealing with on a daily basis. Thank you for having spent this time with us and giving us that insight from your world and good, decent information. So I'm going to open the floor for questions. You can type it in the chat box. I'll try to keep an eye on that. And you're also welcome, those of you that are here in the room with me, to just put your hand up and give me your question. All right, I see, while I navigate the chat box, Brenda, Mike.
Hi, Bernard, it's Mike here. Brenda's on the other side, and she's cross with me because I've logged into her email, her Zoom account, so I'm going to have to get out of here just now. Veronica, firstly, just thanks so much for sharing with us. And yeah, Bernard has already said this. Yeah, we feel for you and your colleagues. One can't imagine. I have friends in the medical world who have said, they just feel desperate and so sad so much of the time. I've obviously been vaccinated, and I'm dearly looking forward to getting a booster shot. And I'm hoping somebody will agree to give me one. But I have been wondering whether, and I'm interested in your scientific view on this, whether it might not be good to, so I had the Pfizer shots, and I'm wondering whether I couldn't have a Johnson & Johnson to mix in there. So how do you feel about like a cocktail of vaccines?
So it's a great question. So scientifically, I think it's a fantastic idea. I think different pathways is a really good idea. And there is some data emerging of mixing of vaccines being a really good idea. Obviously, this would come at a time when we've got more people safe. But I think that is coming. And I think the idea, there's some Pfizer, AstraZeneca data that's looking good. And there are a lot of my colleagues with J&J who have actually managed to get an RNA booster by hook or by crook, or I don't know. But so I think it's a fantastic idea, and I think it is coming. Sisonke are actually launching their trial for a booster shot, which will hopefully start end of October. And that's exactly what we're going to be looking at is using different vaccines. And I think that would be more robust. It makes sense as well in terms of having had natural infection plus the shot gives you much greater immunity. So again, every possible pathway, better immunity. Yeah.
Thank you, Veronica. I think that answers one of the questions that Renate Zipfel also asked in the chat box. So if I turn my attention to the chat box, I see there's a comment from Brenda, a podcast. I've listened to that one. It really is very interesting and good, so worth listening to. Renata also asks, well, she starts off by thanking you and all the healthcare workers who put their lives on the line for us. And so she's asking, will the COVID vaccines be available on an annual basis in future? That was the one question. She asks about the mixing as well, but then say, what percentage of the population should be vaccinated before South Africa and the world really benefits?
Thanks again, really great questions. So the annual vaccine is very likely. It's like with influenza, like with, many of our vaccines, we have to boost. If you're not exposed, then you're going to get waning immunity. And I do think that we'll probably get some really cool influenza, COVID jabs coming out seasonally. What percentage of the population? That is such an interesting question, because we were all fixated on this 2/3 herd immunity concept, right? And actually, I think that is underestimating it if you look at the available literature. What makes it very difficult in our South African context is we have very little understanding really in the bigger context, and there are selected groups, like the blood bank have looked at a study where they do antibodies in patients who donate, but that's a highly selected group. And there does seem to be high levels of antibodies in certain of the communities. So we have to look at what our natural immunity is, which may in some of our areas be higher than in others, simply because of living conditions. I was recently involved in a study where, you know, literally, how do you isolate if your home is very small and there are 10 people in it? So there are certain communities where spread would have been more likely. But if you look at what Prof Marty was predicting, it's probably closer to, you know, 80%, even 90%, some people are punting, to really, really have immunity. So we are very far off that mark.
Yeah, so we really have a lot of work to do.
Yeah.
Brett Hurley is in the chat box saying, thank you for all the time this morning. What is the progress with regards to South Africa producing its own vaccines?
Oh, sorry about that. So South Africa was very involved in the production of J&J. And in fact, one of the big production sites was in South Africa. We have the know-how in South Africa. I really think if we've learned anything from this pandemic is we probably have a lot more skill than we know in isolated pockets. At the moment, the focus has actually been in the transfer of intellectual property for existing vaccines so that we can produce locally rather than produce what is already available rather than develop new. But there are some new developments in the pipeline as well, which may look at different angles of the immune system, T-cell related, etc. But as far as I know, that is still an ongoing process in terms of being able to produce locally, especially with Pfizer.
Thank you. I see Chart Creer addresses some myths, and there's 2 spots in the chat box. I'll read both of them. It also says, thank you for a very clear presentation. I've experienced a large vaccination hesitancy amongst acquaintances, mainly due to the following 2 reasons, and he adds a third one later. First one, he says, if you have recently contracted COVID-19, it is believed that the vaccination within 5 to 6 months is redundant. So that's the one. The second one, he says, family and friends and acquaintances who have experienced severe side effects accredited to COVID-19 vaccinations, such as heart disease, lameness, and death. What are the real facts? And the third one, he says, is it a myth that one possible side effect of the vaccine is loosening of the placenta in the teenage girls and young women? So 3 things that he's asking about there.
All right. So the first is if you've contracted COVID-19, it's the redundancy of vaccines. So I recently had a student who was actually quite adamant that their GP said for the next 3 months they cannot get or pass on COVID at all. They're completely immune. They don't need masks. They don't need anything, which is not true at all. So we've seen patients actually, especially with a varying variant, with the different variants, recontract COVID-19, and you don't have full protection, and the level of antibodies really differs between people. So we've had, and the same with vaccines really, we've had people who have had, if you've had severe COVID and you've been in ICU, the probability is that you've got pretty good immune response. But we've seen people with waning immunity, and it was interesting, even in healthcare workers, our responses weren't always necessarily as high as some of our patients in the studies that we're doing. So really, it's not redundant. You don't, a second challenge, it's like getting only one Pfizer. You know, yes, you can have some immunity, but you can increase the robustness of that immunity significantly with vaccinations. And then the severe side effects. So yes, if you go and look at any vaccine's website, they have transparency on their side effects. The main have been the increased clotting, especially with AstraZeneca. And then the lameness that you refer to is the Guillain-Barré syndrome. So that has been reported with J&J. These are extremely rare, though. We're talking about 1 in 100,000. And the heart issues were in young men with the Pfizer vaccine. So first of all, let me say, with all of these categories, your risk of getting these diseases with COVID, actual COVID, is usually at least 10 times higher than with the vaccine. The second thing that one always has to be careful about, I saw a cartoon recently of somebody that won the lotto, and they said, I got the vaccine and finally I won the lotto. So just because there's a temporal association between getting the vaccine and getting a disease that you had anyways, or exacerbating a disease, certainly you have to be careful. Deaths with the vaccines are investigated thoroughly. So those are really reported on. If you die in a car accident after getting your jab, it's probably not the jab's fault. But certainly in terms of the 3 main side effects, there have been reports, they have been thoroughly investigated. And one thing that I always say to my patients as well is, this is a trigger, it's an immune response. So if you, for instance, have a genetic predisposition to autoimmune disease, this is going to challenge your immune system. And this might actually elicit something that was there already, just like getting a viral infection. So if you think of the lameness, the Guillain-Barré syndrome, what usually triggers that is a viral infection, or other vaccines have triggered that. So we know that that can occur because your immune system is stimulated. And if you're predisposed, you might develop this. But these are really, really rare side effects. The majority of people will only have flu-like symptoms. And we're really talking about the occasional cases, and they are thoroughly investigated. And as far as I'm aware, the Guillain-Barrés have recovered. The myocarditis issues is extremely rare, and it's in a very select population. And then the issue of death, really to attribute death to a vaccine, has only really been in the context of anaphylactic reactions. There was a third question. What was the third?
The third one was whether the vaccine, one of the side effects is the loosening of the placenta in teenage girls.
Oh, yeah. So there is no data that shows that the vaccine in pregnancy, and there's a lot of data actually available now, it's only recently become available, increases your risk of bleeding, which is really the placenta detaching, or of fetal death or miscarriage. So again, there is association of those with actual COVID infection though.
Thank you. I remember seeing some information at some point about when the blood clotting was doing the was being highlighted in the media, that at that point the chances of possible blood clotting caused by the vaccine was less than 1 in a million. And that was with, and your chances of blood clotting with COVID infection was more than 1 in 10. Was the information they had up at the moment. So, all right, I go on to the next one. Let me just see that I'm not missing one. So Andy Wilson is saying, thank you so much for talking to us today. Dr. Ueckermann, why do you think things are getting worse? The infection with fewer comorbidities, longer chronic issues, etc. Is it just a factor of the different variants, or are there other reasons as well?
Yeah, I think it's multifactorial. Certainly the variants play a role. We know that Delta was about 3 times more infectious than its other variants. And it did create, well, we're still waiting for the data to really be released and analyzed, but our sense so far is that we did see more severe disease. One of the really fun things that have been influencing our ICU experience is ivermectin. So a lot of patients who use ivermectin seem to have a very robust cytokine storm, which is a little bit more difficult to get on top of. And we've seen a lot of ivermectin use causing other organ damage because people are using, unregistered products in massive doses. And I think that has certainly contributed as well. And then, of course, exposure. So where I think in the first wave, everybody that could was locked down and hiding, people have become more lax. They have become, there's just a fatigue of COVID. And generally, there is a little bit of a more relaxed attitude. So I think our numbers that we're seeing is higher. So you've got more people infected with a more infectious variant. You're going to see more severe disease. The younger patients has been a real concern, and most of them are in context of their cytokine storm. So that period where you get the viral phase and then the inflammatory phase, and that's where we've been struggling with them. And of course, the virus is mutating to keep up with us. So that would explain most of what we're seeing, I think.
Veronica, I see 3 more questions here. One is from Vera saying, thank you so much for the talk, Dr. Ueckermann. I was wondering what your thought was the best way to combat vaccine or COVID misinformation and hesitancy.
Yeah, I think really we've got to target this at every possible level. So I think each person who's been vaccinated needs to be an advocate for vaccination. To say, hi, I'm alive. I mean, we even saw that with the initial trial of healthcare workers. Remember, we got the J&J on the trial phase, right? And some of my colleagues were literally waiting to see if we survived before they got it. So if we can be advocates in that way, those of us who have been vaccinated, And I think patients need to be advocates. I think patients need to come forward and say, look, this is what really happens in the ICU. I also think, you know, we've got to look at why the mistrust is there. I find it very ironic that people trust me at their sickest to try and save their lives, but they don't trust me when I say, please get vaccinated. So, I mean, the average healthcare professional who's still sticking around and fighting on the front line really is doing this because we want to see the best for our patients. So we're not hiding, you know, we're not hiding information, and we're not trying to chip people. But I also think we need to target who people respect, and that is different for different people. So within our community, prominent people who got vaccinated are deans. There's a lot of information going around. There's students telling other students it's safe. But we need to look at our communities as well. And we probably should have spoken and engaged to our community leaders and our church leaders. I think if we have these people in prominent positions really understand what it's about and really understand, you know, I mean, a lot of people for religious and political reasons will follow what their leaders say. So I think if we engage those people better and really get them an understanding, we might see a decrease in vaccine hesitancy.
Appreciate that. Ish, I see you want to ask a live question. Go ahead.
Yeah, sorry, some of it's been addressed by the misinformation stuff. I just wanted to thank you for the talk. I really enjoyed it. I just wanted to add that one of the frustrations I've had is I feel kind of powerless in terms of like the science communication that's been going on in such a deluge of misinformation, especially from the pseudoscience coming from people with PhDs or medical doctors. And it seems like people that are really influential and maybe even highly regarded academics are playing a role in some of this misinformation. And it's more to express frustration. I just wish there was more we could do. But many of these people are so skilled at hand waving and using the correct language because they've been doing it for years on grants and whatnot. And now they're just repurposing it for really obfuscating information and misleading people. And I just don't know what to do about that part. I feel like as a scientific community, we should have some influence over it, but yeah. So just
I agree. There's never been so much, you know, rapid review happening and so many retractions. I mean, it's shocking that prominent journals have had to retract. I mean, look at the chloroquine saga, you know. I mean, our poor SLE patients couldn't get chloroquine because everybody was popping it. Now, then the ivermectin saga, now Australia's, you know, banned it. It's very difficult, but you're quite right. And I think the responsibility that goes, I don't think people realize the responsibility that goes with being a prominent figure in what you say. I share your frustration, absolutely.
I see the questions keep coming, and Veronica, let's see if we can finish as close as possible to 9:30. We can continue a little bit, but I'm aware of your time as well. So just stop it where you need to. So Kyle is asking, also thank you for a great talk. He's asking about being made about myocarditis and pericarditis after first and second vaccine, the myocarditis for younger patients and pericarditis for older patients. I have no idea what that is. Have you seen it in your time in the field?
Yes, so first of all, for those who still have ongoing questions, I've just put my email in the chat box. I'm happy to continue this. So it's a real issue that has been flagged, but again, we're talking about, you know, 1 in a million with especially the myocarditis in the young people. And so maybe I can contextualize it. We have a colleague who had myocarditis from COVID, right? And it was a real issue for us about whether or not he should vaccinate. And he just said, no, forget it, I'm vaccinating. And even with having previous myocarditis, he actually got the Pfizer and he had a little bit of a spike in symptoms. And then it certainly resolved again after that. And he wasn't any worse off. So with the myocarditis, again, it's going to be those people who are susceptible. It's extremely rare. Those people were probably going to get the myocarditis with COVID anyways. So I've seen many cases of myocarditis associated with COVID infection, especially in young people. And our pediatrician cardiologist actually mentioned a couple of weeks ago that she's seeing these unexplained heart failures. And then when you go back on the history, mom and dad had COVID about, 4 weeks ago. So the kids from COVID, we've seen a lot. I have personally not yet seen a myocarditis induced by vaccine. As probably eventually you will see one just by the numbers. but I've seen plenty from COVID itself. The pericarditis in the elderly also, that's a little bit more difficult because that's a layer around the heart, and there are very many explanations for that. And whether, you know, again, people are very sensitized and heightened to effects of the vaccine, and whether they present with their underlying diseases at that time is interesting to look at. But in my practice, I've not yet seen myocarditis or pericarditis from the vaccine, but it has been associated with the mRNA vaccines, very rarely.
Johannes is also thank you for the talk. Some of the concerns I've heard about is regarding the lack of long-term data. From what I've heard, most drugs take about 5 years to be released, but this vaccine was so quickly developed, they worry about the long-term effects that might arise.
Yeah. Okay, so again, it's important to understand that the process and the platform is not new. Vaccine platforms are not new. So every year we do this, right? We wait for our first influenza cases, and then we produce the new influenza vaccine. So it's not a brand new process, and it's not a brand new drug. However, yes, we can't comment on the long-term effects yet. We've got 18 months data because we've got a year's data because vaccines literally haven't been around long enough. But we can rely on what we know previously from vaccine data and from the physiology. And time will tell, but I think we've really based this on processes and technology that was already in place.
Thank you. Yeah, we always in February, there's always a motivation every year to get the common flu vaccines. And I guess not everybody do, but I guess for many of those, as you say, there is long-term data available. Melissa's asking, this has been really informative. Thank you. I've had family members tell me about the studies published in Israel, where it was reported that for 8 months after recovering from COVID infection, the protection was equivalent to that of the vaccines. In your experience, can this data actually be extrapolated to different populations around the world?
Yeah, so I'm very hesitant, as always, to extrapolate data from one population to another, simply because we are so different. We've seen this with many things, right? So one of the major issues as a sub-Saharan practicing doctor is that most of our data from our diseases comes from populations that are not us, and we see different results. So there's been a lot of interesting queries around that data, but if we look just locally, there's a trend towards certain population groups getting sicker and developing more severe disease. And for instance, people with diabetes, which we know is a lot to do with, yes, partly lifestyle, but there's an immune component too. So genetics and immunology really play a very big role in COVID. And I can tell you, I've got patients who got COVID in all 3 waves with good antibodies, by the way, good antibodies to alpha, and then got beta, and then got delta. So we can't quite extrapolate that. We don't have a lot of South African data, but it is in the pipeline.
Osmond Bolognini, who's here in the audience with me, is asking, so thank you for the informative talk. With the slow uptake of vaccines, the possibility of a 4th wave, and I wonder what your thoughts are on that, you know, when we might expect that, especially now within the politics with the elections coming up. Exodus of medical staff, COVID-19 information fatigue, spatial distribution pattern in South Africa. With this background, what risk are we facing as a country, in particular the health system? Is our messaging effective? This question. What is the risk that you think we're facing over the next, let's say, 6 months to a year? And is our messaging effective?
Right. I think we're facing a crisis that is going to carry on beyond COVID. So just to touch on what you're saying, I mean, in terms of exodus fatigue, the number of colleagues who I know 2 very close colleagues of mine who have given up medicine, they've walked away. But the immigration, the sense that, you know, we're going in circles here is very real. But my concern is beyond COVID. My concern is that in my antiretroviral clinic, in my HIV clinic, people are scared to come to the hospital. So I've got dropout of antiretroviral therapy like I've never had before, which also means that I'm going to see resistance like I've never seen before. We're seeing later diagnosis of tuberculosis. So the collateral effects, you can think for yourself, cancer surgery. If you need cancer surgery and the entire hospital is occupied by COVID-19 and it gets delayed, your stage of cancer is later. So really, we're facing a crisis, and I think there is an idea that we didn't initially want to scare the population, and we didn't want to, and to be honest, if you look at our reporting and our excess mortality data, there's a huge gap. We are underreporting COVID deaths, despite some people saying we're overreporting them. I think they are grossly underreported. So there's been a sense that we've got things under control, and maybe, we don't want population mass panic. But on the other hand, I think it would be a good idea for people to know how serious this really is. So we are facing a massive risk, and I don't think our messaging has been effective. I would love for some of those who really punt severe anti-vax ideas, and we've been made out. I mean, literally, I'm quite vocal about my vaccine policy, my beliefs, and not even beliefs, the science behind it. And I've gotten messages about, I'm going straight to hell, and all of these things. We need to understand that the problem is so much bigger than just the wave in front of us. I don't need to talk to any of you about the economic impact. It's the impact on our kids, the impact on schooling. And so maybe our messaging hasn't been effective. And the fourth wave, I do believe you're quite right, will be coming. I'm really hoping it doesn't reach that black peak of the previous one, because I don't think we can do that again. But it's probably coming early December, maybe a little bit earlier now with the relaxation to level 1, which people seem to interpret as COVID being over, as well as the elections. Yeah,
I share that with you. That fourth wave has touched so many. I think all of us have somebody very close by that was in some way affected during that time. But also for yourselves. Deborah is asking, thank you for the talk. Some people have concerns about the efficacy of the vaccine against the new variants that are arising. Their reasoning is, if the science is saying people who have been infected with one variant may not be immune to another variant, then what are the chances that one type of vaccine can be effective against different variants? What are your thoughts on this?
Right, so our group actually published a paper in Nature earlier this year looking at, we had some antibodies from patients who had COVID in the first wave, and then we actually tested them against the new variants, and we saw that it wasn't as effective. Again, this is lab data. And yes, new variants will emerge. That's what viruses do. And the longer we take to get some sort of, you must understand, a virus can only really replicate and mutate in its host, and we are its hosts. So if we can shorten the time in the host, and we can decrease the number of hosts, we decrease that chance. We've been quite lucky, I suppose, in a way, in terms of the data against Delta, which has been good for our vaccines. But yes, variants can arrive, and really that's why we get the top up each year, for instance, of influenza. But the idea is to just get on top of the crisis and not give time for new variants to continue to arise. So the new variants are going to arise from the unvaccinated areas, like largely unvaccinated like we are. And again, some immunity is better than no immunity. It's like the cumulative immunity from influenza that we know. If you get your shot every year, if there's a massive mutation, your chances are better. So we're not saying that it's going to be effective against every variant. We're saying it's effective against what we have now, and we're trying to prevent further mutations and variants arising.
Veronica, you'll just tell me to stop at some point, and I'm going to ask people to maybe keep the questions in the chat box to absolutely essential things you're still burning to ask, but just cut us off when we're done, Veronica. Zoraida asking, can data convince lay people of getting vaccine? So data, hearing stats on the risk of getting side effects from the vaccine versus COVID itself help to overcome vaccine hesitancy.
For some people who understand data, data is great. But you and I know we can swing data and color data to sort of make it suit the agenda. One of the examples is there was an increase in number of hospitalized vaccinated people reported. I think it was in the US. But if you go and look at it, all that happened is there was a larger number of the population vaccinated. So if you compared unvaccinated to vaccinated, it was much lower in the vaccinated group. But yes, more of the people infected in total compared to the first wave were vaccinated because vaccines are available, that kind of thing. So I think data that is, and we probably need somebody in the middle, isn't it? Because we've got scientists, and our scientists studied 12 to 20 years to do what they do. And then we've got the lay person who sometimes thinks that Google, you know, I can make my own informed decision. And we've seen on the social media some really severe reactions to that from scientists and from doctors, etc. So I think we need safe sites. We need almost places where people can go as patients, and data is interpreted in a friendly way, in a context. Where I always tell my registrars, we have this site called The Bottom Line. So if a study comes out, it's really nice. They dissect the strong points, the deficiencies, and then the bottom line is, what does this really mean? And I think we need that interplay maybe, and then we can use data to convince people. Data like decrease in death in hospital, or 87% of the ICU is unvaccinated. I think that can really help us get to lay people. But when it comes to variants, etc., it can be very confusing if you're not used to dealing with these issues.
Ali Nashwa is asking, is it referring to one of the conspiracy theories that's saying, you know, we haven't got a vaccine for HIV, cancer, and all of those ones. Why is this one been developed so quickly? And explaining that HIV and cancer are completely different beasts in the opinion, but a little hard to explain to someone without a science background. What's your opinion on such conspiracy theories? How do we quell them?
Yeah, it's so difficult. And again, it's got to do with background. So 10 years ago, I mean, literally, your doctor would say, you need to take out your appendix, and you would sign the form and go get your appendix taken out. Now you're going to go for a second or third opinion. You're going to Google all the side effects. You're going to blame your doctor for not saying that thing that occurred in 1 in a million. It's very difficult with the information available for patients. The conspiracy theory about HIV, that's at least an easier one, because HIV is a retrovirus. It's one of the most clever viruses, because retrovirus, you know, per definition, it enters your own cells. There's an involvement of DNA. It's a lot more difficult to get on top of, and that vaccine platform has been ongoing for years. Corona, thankfully, is a little bit of an easier virus, and you know, more like the influenzas and those kinds of things that we were more comfortable with. So yeah, these conspiracy theories, again, you know, and somebody mentioned it, it's often educated people punting it, which makes it so difficult. I really feel sorry when you know, something around engineering, I know nothing about engineering. So if somebody has to give me opposing opinions as professionals, that would really distress me. So again, I think we need good, trustworthy information from people that the community actually trust.
Yeah, and you mentioned those that go in between, and I'm hoping that a number of people today would be committed to being even more of an in-between to their communities. Last 2 questions here, Veronica. So thank you for this. Daniela is saying, what are your thoughts on the mandatory vaccinations? Do you think it's the only way through this is forcing people to get vaccinated? So
we were actually on a safety committee meeting just at the start of vaccinations, and somebody brought up the topic. And I honestly, and again, it was probably naive because of my perspective, but I said to them, you know what I foresee is people fighting to get vaccinated. You know, people are going to be really upset. Why do I have to be over 60? So we were anticipating a completely different uptake. Again, because of my perspective, I think if people are not going to get vaccinated, there should at least be some benefit and some consequence. So in Canada and the United States, they're talking about using that as one of your triage criteria. These are tough things, but if I have one ventilator and I have a patient who was vaccinated and I have one who wasn't, that was their choice, who should get the ventilator. And seeing this as a way of taking care of yourself, I think the travel restrictions will be obvious, and those are hopefully things that will drive people. But we might have to look at mandatory vaccinations. I don't see that being taken well, though. People will really see that as an infringement of their rights. And I would hope that we can do it in a kinder way, or do it through information rather than mandatory, but it might well be coming. And if it's necessary to get back to some kind of normality, so be it.
Thank you. Yeah, I'm hoping that today's talk is going to make that less necessary, at least for this community and associated. Lydia is saying, thank you for the information. How long should a person wait after one has had a normal flu to take the COVID vaccine? Is it safe?
All right, so we usually say if you've had a viral illness, you want complete recovery for at least 2 weeks before you consider, or if you've had another vaccine, such as a hepatitis vaccine or anything, before you challenge. So if you had flu for 5 days, the day that you were better, start counting from there, and then at least 2 weeks.
Right, thanks. And Ash is just saying he's had a great experience at the UP vaccination site. One of the things that I'll commit to this community that we'll do afterwards is just to make sure everybody, can use that form and has transport to get there. And if we can help people overcome that we'll try to do so. But I've heard that many people say that was a great experience at the UP site. Anthony Hopton saying, thank you for the informative talk. I've heard of this concept of a leaky vaccine, which originated with Murek's disease in chickens. Essentially, a vaccine was introduced which did not fully prevent infection, but provided selection pressure, which caused the virus to mutate, to become more resistant to different prevention measures. Some people say that because of COVID vaccines also do not provide full protection, that it's also a leaky vaccine. Have you heard of this? And what is your view on that? And I'm going to make that the last question.
Right. So again, this is part of really building the ship in the middle of the storm, isn't it? So if you look at efficacy for severe disease, we actually do have quite a good percentage. I mean, it's different between the different vaccines, but we're talking more than 85% efficacy against severe disease. With the concept of a leaky vaccine, if we could have had a mass universal one-day jab, everybody in the world, that would have been fantastic, because I think a lot of what we're seeing and a lot of the risk that we're seeing is this lag and this difference. And the WHO slogan, we're not safe until everybody's safe. The developed countries realize that a little bit too late, and that we're going to keep generating. So the idea, if you don't have a significant amount of protection, I think in South Africa, we would rather be facing it in terms of numbers of people vaccinated that allows for more mutations than the vaccine in itself. If we could get mass vaccination going quite quickly, then we would be able to get onto the mutations a lot better, and then blaming the vaccine in itself for being so-called leaky.
Great. Yeah, I guess it's a lot more leaky, if people are not vaccinated, the number of people that are not vaccinated at the moment. It's a much bigger leak at this point, I guess.
Absolutely.
Veronica,